Hi, I'm Lisa Washburn, Associate Professor and Community Health Specialist with the University of Tennessee Extension. I'm part of the professional development team for the Well Connected Communities Project. I'm pleased to share with you the training I developed on health behavior change. Sometimes the best of intentions to eat healthy and exercise regularly don't translate to action. Sustained behavior change for ourselves and for others can be challenging. This module covers health behavior theories that can help in understanding our own behavior and the health behaviors of others. First, we'll lay groundwork by defining theory and touch on the role of theory in program planning and implementation. Then, we'll specifically discuss three theories or models: the social ecological model, stages of change model, and the health belief model. We will also discuss how these three models can help inform community-level outreach work. So why study health behavior theory? Theory is a way to help explain health behaviors and the context in which they occur. Health is influenced by many factors. Sometimes knowing what to do does not translate into making the best choices for good health. It's been said that knowledge is not sufficient to change behavior. Humans are influenced by family, peers, and environments. We are also influenced by the media and social and cultural norms. In short, health behavior is complicated. Health behavior theory helps us sort out and make sense of complex factors. It's not just that we know but don't do. As was mentioned, knowledge alone does not change health behavior. When reflecting on the choices of others, we may wonder why they make the choices they do, when the health implications seem so clear. It can seem to be a mystery. We may also reflect on our own choices at times. If you think back, I bet you can come up with a few examples of times when you didn't make the healthiest choice, even when educated on the right choice to make. On a positive note, let's think of another example. Can you think of a situation where you usually or always make the healthiest choices? Perhaps you stick to a regular exercise routine. If you take medication for a chronic condition, maybe you diligently track medication adherence or have a reminder system in place. There are likely many factors impacting health habits, and knowing what to do is one small piece. Knowing what to do isn't enough. Willpower alone isn't enough. Health behavior is complicated, and our choices can be influenced by environmental factors. Theory is defined as a set of interrelated concepts, definitions, and propositions that explains or predicts events or situations by specifying relationships among variables. In plain language, theory helps us explain or predict why and how things happen. Theories and models help explain behavior and suggest how behavior can be changed or influenced. This is important information for those developing programs aimed at influencing behavior, whether at the individual, family, or community level. Understanding and using theory or behavioral models informs design of effective programs. It also helps those involved in community outreach target activities to meet people where they are in readiness to change. It also helps us take into account contextual factors like healthy food access. For example, Conducting a class on how to prepare fresh produce might be better received if the target audience has access to fresh produce and the ability to purchase it. In this example, knowing that access to fresh fruits and vegetables could be a contextual factor helps us identify external influences on behavior. If our goal is to increase consumption of fresh fruits and vegetables, we need to delve deeper than increasing folks' knowledge of how to prepare it. Changing dietary patterns might involve intervention beyond education. Oftentimes, our community program efforts aim to raise awareness and increase knowledge. Ignorance may be one piece of the issue, but it's not the whole story. Supporting behavior change is important. We can make the healthy choice the easy choice by reducing barriers to healthy choices. Barriers include things like access to places to be active and access to healthy foods. Barriers also include things we usually overlook, like whether the healthiest options are most visible. Barriers can also include social norms and personal attitudes. The social ecological model provides a framework for thinking about the many influences on health and behavior. Often, these influences interact. The social ecological model suggests that health is affected by the interaction between the individual, their friends and family, referred to as the interpersonal level, the organizations they are part of, such as work sites and faith-based groups, and the community. We are also affected by physical, social, and political environments. People are impacted by the context in which they live, and likewise, people influence others in the environments they live in. This can be very basic, like providing healthy food in your household. It can also be very complex and policy-oriented. It can be positive and improve health, or negatively influence health. Health behavior theories addressing different levels of this model are available to guide us as we choose where to focus our efforts. For example, some theories are specific to the individual level, while others address the interpersonal level or our relationships. These theories are inherently broad, abstract, and not topic specific. They can be applied generally across topics to help develop programs that will be effective. The main idea with the social ecological model is that programs should target individuals and impact the interpersonal, community, organizational, and environmental factors influencing health. Addressing multiple levels helps programs to be most effective. Here's an example of how a program focused on the individual level can be expanded to address other levels influencing behavior. Imagine that your group is passionate about getting teens to drink more water. Sugary beverage consumption is linked to health issues that have increased in your community, and you're working together to determine the best course of action. A simple, direct approach might be to go into the school setting with an educational campaign to teach students to rethink their drink and choose water instead of soda. Think for a moment. If your group were in this situation, how would you proceed? Now, imagine such an educational effort in a school where there exists an environmental barrier. The water fountains are unappealing. Maybe they lack pressure and students have to lean down really close to drink. Perhaps the fountain surface has mineral deposits that make the water fountain appear unsanitary. Add to that a policy barrier within the school that does not allow water to be brought into the classroom. Consumption is limited to between class breaks and lunch. Even the best educational campaign will fall short of the goal increasing water consumption among teens without some additional supports. An approach that goes beyond the individual level, where we're hoping teens will trade soda for water, an individual choice, will address the policy and environmental barriers. One group's approach was to work with school administration and raise funds to purchase and install water filling stations and purchase water bottles if the school passed a policy allowing water throughout the school day. This addressed the individual and organizational or setting level and an environmental factor influencing health. In this example, healthy beverage consumption. This is an example of working across levels of the social ecological model. As we move from the social ecological model to discussion of other theories, it's important to note that many successful approaches integrate pieces of several theories, frameworks, or models. In fact, you will likely see some commonalities between the theories discussed here. The social ecological model, health belief model, and stages of change are some of the most widely used theoretical models. That's why we have chosen to describe them in this module. The health belief model is used to help explain why people do or do not adopt recommended health actions. A person's beliefs about their susceptibility to an illness or condition, how severe it will be, and their perceived benefits and barriers impact behavior. A few important assumptions underlie the health belief model. The health belief model assumes that people make the best decisions if they feel it is possible to address the health issue, if they believe that taking action will be effective, and if they believe they are able to take action or make change. The health belief model also assumes that people are rational, and we know that that isn't always true. We will focus on 6 major constructs of the health belief model: perceived susceptibility, perceived severity, perceived benefits, perceived barriers, cues to action, and self-efficacy. Perceived susceptibility and perceived severity are 2 important health belief model constructs. The word perceived is important here. Perceived means to interpret in a particular way or regard as. Perception is subjective and shaped by individuals. Perceived susceptibility refers to a person's belief about their chances of getting a given condition. For a person to take action, they must believe they are at risk. When people believe they are at risk for a disease, they will be more likely to do something to prevent it from happening. The opposite is also true. When people believe they are not at risk or are at a low risk, they tend to have unhealthier behaviors. Perceived susceptibility alone is not enough to cause behavior change. For example, older adults are among those most at risk for foodborne illness, often with serious ill health effects. Older adults may know they are at risk for foodborne illness, but still not use safe food handling practices. Perceived severity refers to a person's belief about the seriousness or severity of a disease. Severity can be based on medical consequences like death or disability, or personal beliefs about how the condition or disease would affect their life. For example, some people do not get the flu vaccine for various reasons. They likely know they can get the flu, but perhaps they believe that getting the flu will not be serious. However, getting the flu can be very serious for some groups, like older adults and people with asthma. Perceived severity may also be heightened among those who are self-employed, because missing a week of work means reduced income. When perceived susceptibility and perceived severity are heightened, people are more likely to take action. Education can help correct misperceptions of potential susceptibility and severity. People need to know how a condition will affect their lives and the consequences. Susceptibility plus severity means a perception that I can get it, and if I do, it will be bad. Next, we'll discuss perceived benefits and perceived barriers. In assessing perceived benefits, one might ask, if I comply with the health recommendation, will it work? What are the chances that it will work? Perceived benefits reflects a person's belief that taking action reduces risk, their susceptibility, or seriousness, the severity of the condition. Based on our assumption of rationality, we know that people will not act unless they believe the action will make a difference. And because of that, people need to know how changing right now can help. The benefits need to be relevant in the short term. In our flu immunization example, a person would need to believe that the vaccine will work, and there will need to be few barriers to getting the vaccine. Barriers may be having to take time off work for a doctor's appointment or having to pay out of pocket for the vaccine. In assessing barriers, one might ask, how much will the recommended action cost? Barriers or costs are often not monetary. Sometimes time is a barrier. Often, fear can override the benefits of taking a recommended action. This may be true for some in getting cancer screenings. They may be afraid of finding out that they are sick. A person without health insurance has an additional element of the fear barrier. If they are diagnosed with cancer, they may be unable to cover the cost of treatment. Perceived barriers represents one's opinion of the tangible and psychological costs of taking the recommended action. There may be a conscious or unconscious weighing of costs and benefits. If one doubts their ability to take the recommended action, particularly something long-term like a dietary change, this is a barrier. When working in communities to improve health, we will need to think about the potential benefits and barriers and consider ways to increase the benefits and address the barriers up front. Sometimes reducing barriers involves building confidence. Sometimes it simply involves increasing access. We've discussed perceived susceptibility and severity and perceived benefits and barriers. Two main constructs of the health belief model remain: cues to action and self-efficacy. Cues to action are events, people, or things that trigger people to change behavior. Cues may be external influences promoting the desired behavior. Advice from others, the illness of a family member, or a newspaper article can serve as a cue. Fast food restaurants that post menu items with calories offer a cue to consider calorie content in food choices. Posters in public restrooms offering hand washing cues are a reminder to wash your hands. Highway signs to buckle up provide cues to action. Calendar reminders and cell phone alarms can also trigger action. Cues can be internal, such as chest pain, discomfort, or fatigue. In our flu example, a cue may be a loved one offering gentle but consistent reminders to get immunized. Cues could also come from posters or other reminders like an email message or social media post. Cues can be positive or negative and trigger behavior one is trying to stop. Television and billboard ads promoting fast food can provide a negative cue. Environmental cues for one trying to quit tobacco may be visiting familiar settings for tobacco use or being around others using tobacco. Cues to action can be planned to help people stay on track. This should be considered in community program efforts. What sorts of cues will be helpful? It may be reminders, phone calls, or email. It could be printed material or a poster. Think about the issue you're addressing and the target audience. Self-efficacy is a person's confidence and belief in their ability to take action or perform a given behavior. People generally do not try to adopt new behaviors unless they believe they can do them. If someone thinks altering their behavior is worthwhile, a perceived benefit, but is unsure of their ability to make changes, they are unlikely to attempt lifestyle changes. Said another way, a person may believe that living a healthier lifestyle has significant benefits. However, if a person believes they will be unable to address barriers to making changes, they most likely will not alter their current behaviors. Self-efficacy can be increased with encouragement, training, and other support. We discussed the 6 major constructs of the health belief model. These constructs provide a helpful way to make sense of health behaviors. While we did not explicitly address knowledge, attitudes, beliefs, and motivations, these concepts influence behavior. For example, can you think of how attitudes might impact one's perceived susceptibility? Or how personal beliefs may impact ideas about perceived barriers? Might motivation affect one's perception of barriers? Models are useful because they help us understand and predict, but they are not as black and white as they may appear. Knowledge, attitudes, and beliefs are nearly always at the heart of our behaviors. Let's review the health belief model components. We know that individual perceptions like perceived susceptibility and perceived severity influence how we perceive the threat. Cues to action also influence that perception. Perceived barriers and perceived benefits feed into one's likelihood of taking the recommended action. And finally, gender, age, ethnicity, personality, socioeconomics, and knowledge are all factors that influence the model as a whole. These factors underlie whether we take the recommended health action or not. Here's a scenario to consider. Robert smokes and thinks that information on lung cancer is overrated. His grandfather smoked all his life, and he lived to be 90. Which construct or constructs of the health belief model would be helpful to address first? Correcting misperceptions could be important. Robert appears not to recognize his true risk of negative health outcomes. This is perceived susceptibility. Additional information about Robert's life situation could help us address perceived severity or benefits and barriers. Perhaps Robert is a father and is exposing a young child to secondhand smoke. Educating Robert on how secondhand smoke increases health risks for his young child may alter his attitudes and increase the perceived benefits of trying to stop smoking. And his child's susceptibility could increase motivation. If we think back to the social ecological model, what additional efforts might impact Robert's tobacco use? Policies limiting or restricting use in public places could prohibit tobacco use, regardless of his health beliefs. Laws restricting smoking in vehicles with children could protect his child in this setting. Next, we'll discuss the stages of change model. Stages of change is part of the trans-theoretical model and is used to help guide planned change efforts. Long-term health behavior change takes time. Just as the health belief model involves multiple factors, long-term change requires multiple actions and the ability to monitor and adjust our plans. The Stages of Change model helps explain the process of behavior change. It is concerned with a person's readiness to change. Change is a 5-stage process. People go through these stages at their own pace. The Stages of Change model evolved from work with smoking cessation and the treatment of drug and alcohol addiction. It has been applied to a variety of other health behaviors, including healthy eating and physical activity. The basic premise is that behavior change is a process and not an event, and that individuals are at varying levels of motivation or readiness to change. People at different points in the process of change respond best to efforts tailored to their particular stage. This model can help us understand why people who are at high risk for certain conditions, like heart disease, may not be ready to try to change their health behaviors. If we are targeting community efforts to such individuals, it can help with planning program components to address the varying levels or readiness to change to help people be successful in their change efforts. We can also look at how organizations or communities change using the 5 stages. For example, individual behavior is affected by multiple levels of the social ecological model. The individual with heart disease may be an employee whose worksite lacks environmental supports for healthy foods. For example, the worksite may lack refrigeration or adequate sink space for rinsing and preparing fresh fruits and vegetables. We can use the stages of change to look at how the worksite as an organization might progress and make supportive environmental changes. As the image on this slide depicts, the stages of change exist in a particular order. It is unwise to skip steps or rush an individual through one stage to the next before they are ready. This makes the maintenance of change less likely. The image here makes the stages of change appear linear, but it can be described as more of a cycle. The graphic here adds an element, relapse, and shows how one can move in and out of any stage at any point. For example, a person may be in the action stage. If change efforts are stalled, that does not necessarily mean he or she backslides into the previous stage, in this case, preparation. It's more likely that if change efforts are halted, the person could move back into the relapse phase and may then need to start over at the contemplation stage. Next, we will discuss each stage in detail. Pre-contemplation is the first stage of change. At this stage, a person may be unaware that there's a problem or that there's a need for a behavior change. In pre-contemplation, the person is unaware, unwilling, or too discouraged to change within the next 6 months. They may not know that change is needed. If change is attempted at this stage without going through the contemplation and preparation stages, old behaviors are often reverted to and the change is not successful. In the pre-contemplation stage, people are not thinking seriously about changing. People in this stage may defend their current bad habits when other people pressure them to change. They do not see their behavior as a problem, and they may be unaware that a problem even exists. In pre-contemplation, the person does not see the behavior as a problem and is not interested in discussing the behavior with others that do see the behavior as a problem. In pre-contemplation, a person has no intention of changing their behavior and may be unaware of the risks or easily rationalize them. And also in pre-contemplation, a person may have made previous attempts to change and they feel hopeless about their ability to change. In an example, let's consider the case of Ginger. Ginger has no desire, thought, or intention of starting an exercise program. We'll follow the case of Ginger throughout the stages of change. The next stage is contemplation. In contemplation, the person is thinking about changing a behavior within the next 6 months. In the contemplation stage, people are more aware of the personal consequences of their habits. They may spend time thinking about the problem, but have not made a commitment to take action. Although they are able to consider the possibility of changing, they tend to be hesitant about it and may weigh the pros and cons of changing their behavior. They may be unsure if the long-term benefits outweigh the short-term costs. People in the contemplation stage may be more open to receiving information about behavior change than before. They are also more likely to take advantage of educational opportunities. This stage may last a few weeks or forever. Some people spend a lifetime thinking about change but never take action. In contemplation, the person has some awareness of the need to change the behavior and begins to realize the risks of their behavior. In this stage, a person is actively weighing the pros and cons of the behavior and may express an awareness of the need for change, but may waver in their willingness to change. In our example of Ginger, who is considering exercising, if she's in contemplation, she considers starting an exercise program but is not ready to begin yet. She has a friend who recently started attending a community class. In the next stage, preparation, one begins making some plans and intends to take action within the next month. In the preparation stage, a commitment to change has been made with change intended in the next month. Research on making the change, such as gathering information and developing strategies, identifying resources, are typical. Preparation is an important stage to make action more successful. Skipping from the contemplation stage to action without the necessary preparation makes maintaining the change less likely. In preparation, a person believes that the behavior can be changed and that he or she can manage the change. People in preparation have often made some successful attempts to change in the past. Someone in this stage may express their intent to change and likely clearly sees the benefits of changing the behavior. One may doubt his or her ability at this stage. We can target our efforts to help build confidence and provide opportunities for folks to test the waters. Following our example of Ginger, who wants to start exercising, in this stage of change of preparation, she buys a new pair of athletic shoes and workout clothes, and she also researches several nearby gyms to find out their costs and their benefits. Next is the action stage. This stage follows preparation. If the preparation stage is skipped or rushed through, success at the next stage may be less likely. In action, the person is actively doing things to change or modify a behavior. This stage involves the most time and energy. Relapse risk is greatest in the action stage. To be successful in this stage, which can last from 3 to 6 months, one must think about barriers they might encounter and strategies to overcome them. Setting short-term goals can be helpful. Motivation can be sustained by rewarding success and asking friends and family to help with accountability. People in this stage are likely to seek support from others. An environment supportive of the new behavior is essential. In the action stage, a person has begun to make the behavior change, whether they're at the first day or 6 months down the line. In this stage, they are emotionally, intellectually, and behaviorally prepared to make the change consistently. Someone in the action stage has expressed a commitment to change, and they've developed plans to maintain the change. Revisiting our example of Ginger and her exercise plans, in the action stage, Ginger makes it her goal to exercise 3 to 5 days a week for 20 to 60 minutes a day. Let's discuss the maintenance stage. In maintenance, the person continues to maintain the behavior change for at least 6 months until it becomes permanent. In the maintenance stage, the focus is on maintaining the new behavior and resisting temptation to return to old habits. During this stage, it is important to anticipate situations and barriers that could lead to relapse. Coping strategies should be planned in advance to avoid relapse when barriers are present. In maintenance, the new behavior is practiced consistently for over 6 months. The new behavior is becoming a habit, and the person expresses confidence in their ability to continue the change. And revisiting our example with Ginger and her exercise habits, in the maintenance stage, Ginger has been exercising as a new habit and will continue to include it in her schedule for the long term. Relapse is common when trying to change a behavior. When a person relapses, they fall out of their new habits and return to old, unhealthy behaviors. While relapse can be discouraging, it is important to consider what triggered the relapse and to restart the process again at preparation, action, or in the maintenance stage. Revisiting our example of Ginger, she went on vacation for a week and she had difficulty getting back into her exercise routine. Ginger relapsed. But rather than count this as a failure and giving up, she reviewed her goals and she determined how she could start her exercise program again. We've discussed the stages of change. Now let's work through some scenarios. Gail knows that she needs to be more consistent with her blood pressure medication, but she keeps forgetting to take them when her life gets busy. What stage of change is Gail in? Gail is in the contemplation stage. She is aware change is needed, but she has not taken any steps to prepare for making a change. So how might we help Gail to progress to the next stage? Some options may be providing strategies for remembering to take her medication. This could include setting up notifications on her phone. We could also provide support so Gail increases confidence in being able to adhere to her medication. And drawing on the health belief model, we may also increase perceived severity of not taking blood pressure medication as prescribed, such as increased risk of stroke. On the positive side, benefits of medication adherence, like feeling better, could also be promoted. This scenario addresses the community level. Some members of the All Faiths Church have noted rising overweight and obesity levels among children attending the church's evening outreach program, and they wonder what can they do to help the children be healthier. What stage of change describes this faith community? The answer is contemplation. They are in contemplation because they are aware of the problem but have not started preparing to take action yet. What supports could help move the group in this scenario to preparation and to action? Elaine has tried to quit smoking many times and knows that she can do it. She relapses in stressful family events like her mother's death. She's planning to quit soon and has thought through strategies to prevent relapse when family stress intervenes. She knows that she feels better when she is not smoking. What stage of change describes Elaine? The answer is preparation. Elaine is in preparation because she is planning to quit soon, she recognizes her triggers, and is thinking through strategies to prevent relapse. It's important to note that Elaine has been in action before. This will not be her first quit attempt. She relapsed during prior efforts and moved from action back to earlier stages in the change model. If she had given up on quitting, what stage would she be in? She'd be in pre-contemplation or perhaps contemplation. And if Elaine had moved from relapse to thinking through what went wrong, we may describe her as falling into the preparation stage. Tom, a police officer, failed his annual physical fitness test for the first time. He has a diet that is high in caffeine and fat, primarily coffee, energy drinks, and snacks because he feels hungry. Tom has little time to cook, and he chooses to eat convenience and junk food. He's gained 20 pounds since his last fitness test and realizes the need to make dietary changes. Tom would like information on what he can do in the next few months to get ready to make healthy lifestyle changes. What stage does Tom's behavior fall into? The answer? It could be contemplation or maybe preparation, depending on how far he's gotten with finding information. This is the final scenario. Carla has been going to the gym 3 times a week for almost 9 months. She feels very motivated and can't imagine not exercising. What stage of change is Carla in? She's in maintenance. Carla is in maintenance because her behavior has been consistent for more than 6 months. This module discussed the social ecological model, health belief model, and stages of change. Each model can be used to guide efforts to improve community health. Successful approaches usually include more than one theory or model. As you think through your personal and group goals, you may find ideas from several models emerge. We began by discussing how knowledge does not necessarily lead to behavior change. We hope your level of knowledge has increased from exploring content in this module, and that you will apply your new understanding of health behavior at the personal or individual level, as well as within your other spheres of influence. Maya Angelou is quoted as saying, "Do the best you can until you know better. Then when you know better, do better." With that in mind, we all have a responsibility to take action within our spheres of influence, personal, home, organizational, community levels, and beyond. We have a responsibility to support the healthy habits of others, to make sure the healthy choice is the easy choice. We are examples, not just with personal behavior, but with the decisions we make that impact others. Small decisions count, like what you decide to contribute to a potluck, or whether you support healthy beverage policies at your work site. Thank you for completing this module on health behavior theories.